to the Explainer, fellow medicos. Today, we're tackling a high-stakes, everyday reality on the hospital wards, geriatric polypharmacy. You know, when you're managing older adults with complex comorbidities, a patient's medication list can quickly turn into a total minefield. It's really not just a simple matter of adding or subtracting drugs. No, it's about life-or-death clinical reconciliation. This explainer is specifically designed to transform exactly how you approach these absolutely critical transitions of care. Okay, let's dive right into this staggering global statistic. Medication errors are literally the #1 preventable cause of patient harm globally. Just pause and think about that for a second. We spend years, decades, mastering complex pathophysiology and surgical techniques, yet the most common way our patients are inadvertently harmed is through entirely preventable prescribing and reconciliation errors. This isn't just some administrative headache, it's a massive, massive driver of morbidity and hospital readmissions. So here's our roadmap for today. 1. The geriatric polypharmacy crisis. 2. Case study, medication failure. 3. Fixing the broken system. 4. High-yield clinical tools. And 5. The 5-step protocol. Let's kick things off with Section 1, the geriatric polypharmacy crisis.
You see, polypharmacy isn't merely a localized, one-off mistake made by a single distracted doctor. It's a compounding systemic failure where overlapping prescriptions just slowly build up into a toxic cascade. When we break down these medication errors, the distribution is incredibly revealing. 31% of these errors are dangerous interactions, like, say, missing warfarin mixed with NSAIDs at discharge. But right behind that, at 28%, are omissions. In the surgical world, chronic medications are frequently held perioperatively, and then, well, they're simply forgotten. Throw in 23% duplications where two totally different teams prescribe the exact same drug class, and 18% dose errors, often from failing to adjust for geriatric renal impairment. And you've got a perfect storm.
Moving on to Section 2, Case Study, Medication Failure. To see exactly how these statistics manifest on the ward, let's treat this like a high-yield board exam question. All right, we have a 75-year-old male admitted for an elective knee replacement. His pre-admission medication list includes warfarin, metformin, atenolol, and aspirin. Post-operatively, the surgical team starts him on enoxaparin for DVT prophylaxis and naproxen for pain management. Then, on day 4, he develops a massive GI bleed. Look closely at those two lists. Can you spot the lethal interaction that caused this readmission before we reveal it?
And this brilliantly illustrates exactly what went wrong. The patient was already on aspirin. The surgical team added naproxen and NSAID. Then, on top of the pre-existing warfarin, enoxaparin was added post-op. This combination of aspirin, naproxen, warfarin, and enoxaparin is a direct, undeniable pathway to a super high GI bleed risk. This right here is a classic medication reconciliation failure. Notice the duplication risk, too. If a ward physician had casually added metoprolol while the patient was already on atenolol, we'd be looking at severe bradycardia.
Which brings us to Section 3, Fixing the Broken System.
So how does an obvious collision like that happen in a modern hospital? Well, the harsh reality is that bad systems beat good doctors every single time. We have care silos. The surgeon is laser-focused on the knee and post-op pain. The ward physician is managing the diabetes and hypertension. They're relying on informal mental checks, and their electronic medical records completely lack cross-specialty flags. When specialists prescribe in silos without talking to each other, critical interactions just slip right through the cracks.
We really need to contrast those dangerous care silos with the ultimate solution, the unified hub model. Instead of fragmented, broken communication, you place a dedicated clinical pharmacist right at the center of the workflow. This pharmacist integrates the surgeon's orders, the ward physician's chronic management, and all the EMR data into one cohesive picture. The pharmacist acts as the ultimate safety filter, literally preventing the duplications and fatal interactions we just analyzed in our case study.
Next up, Section 4, High-Yield Clinical Tools. Having a clinical pharmacist is absolutely crucial, but what evidence-based tools should the entire team be using to evaluate these lists? Well, here we have two absolute gold standards in geriatric care: the American Geriatric Society's Beers criteria, updated for 2023, and the STOPP screening tools. Guys, these aren't just academic guidelines to memorize and forget. These are high-yield clinical pearls that should dictate every single prescribing decision you make for a patient over 65.
Now, what's really interesting about this breakdown is how it ties directly to preventable morbidity. The Beers criteria tells us exactly what to avoid. Always avoid benzodiazepines, like diazepam in the elderly. They are a massive driver of falls and dependence. Digoxin doses over 0.125 milligrams a day? Those easily lead to toxicity. First-generation antihistamines cause severe CNS depression. And look at the caution list.
Long-acting sulfonylureas, like glibenclamide, are notorious for causing prolonged, highly dangerous hypoglycemia in older adults.
Complementing the Beers criteria is the stop-start algorithm. STOPP tells you when to deprescribe. For instance, stopping PPIs if they've been used for more than 8 weeks without a clear indication, or stopping aspirin if there's zero history of cardiovascular disease. But the START criteria? It is just as vital. It reminds us that omitting the correct therapy is incredibly dangerous. If you have an osteoporotic patient over 65 on chronic steroids, you must start a bisphosphonate. If they're fall risk, start vitamin D.
And finally, Section 5, the 5-step protocol. So we know the stats, we know the system failures, and we've got the clinical tools. But how do we actually implement this reconciliation process on the hospital floor tomorrow morning? Let's see how this builds into an end-to-end continuous safety loop. This is the 5-step medication reconciliation protocol. It takes the patient from the chaotic moment of admission all the way through to post-discharge follow-up.
The secret sauce here is the strict temporal benchmarks. Step 1 happens within 24 hours of admission. The pharmacist must collect the best possible medication history from at least 2 different sources. Step 2 requires mandatory review before any specialist adds a drug. Step 3 is a critical high-risk point, transferring from the ICU to the general ward. This is exactly where you must verify renal dose adjustments, because kidney function fluctuates. Step 4 prepares for discharge, and Step 5 ensures 7- and 30-day teleconsults.
Let's zero in on Step 4, the discharge phase. This Pharmacist Discharge checklist is the exact tool that prevents our earlier case study from ever happening again. You must provide one unified medication list to the patient. No confusing partial lists from different specialists. All discontinued hospital drugs must be clearly explained. And crucially, a GP referral letter is sent, which completely closes that siloed communication loop between the hospital and primary care. So the crucial point here is that even with perfect physician alignment, patient education is your absolute final safety net. If a patient goes home and doesn't know the specific emergency criteria to look out for, the protocol is incomplete. You've got to clearly define that they need to call immediately for signs of bleeding, altered consciousness, unexpected chest pain, or severe vomiting. Empower the patient to be the final check in the system.
Despite all the evidence proving that these systems save lives, I want to leave you with a rather shocking statistic. Currently, only 12% of Indian tertiary hospitals have structured medication reconciliation protocols actively in place. Think about that. That means the vast majority are still operating in those dangerous care silos we discussed earlier.
Which brings us to a final, tough question for you as a medical professional. Is your clinical environment part of the 12% proactively securing patient safety, or are you part of the 88% still relying on broken silos and just hoping for the best? Medication reconciliation isn't just annoying paperwork. It is a core clinical competency. Champion these high-yield systems on your wards, utilize your clinical pharmacists, and protect your vulnerable geriatric patients. Thank you so much for joining me for this explainer. Keep learning, keep questioning, and let's go fix the system.